पूनम जी, मिस पूनम,
are talking to
पूनम
champions only. All of them have said that they are joining.
मैडम 15 मिनट ही बचे हुए हैं. आई एम वरीड, यू नो.
I'll call them again because दोनों से बात किया and सबसे बात हो गई है.
ठीक है.
सचिव अग्रवाल has given पड़ेगी but I'm still sending.
वाईफाई कौन सा है?
ये कोई नहीं ज्वाइन किया है. एटलीस्ट वो सुब्बा को तो बोलिए जल्दी आए. कुब्बा को सॉरी. हाँ जल्दी बोलिए बिकॉज क्या है एक बार उनका चेहरा देखने उतरने में ही 15 मिनट निकल जाएंगे.
पूनम जी, आपने मुझे इंट्रोडक्शन मिलाकर सिर्फ 3 पीपीटी दिए हैं, राइट?
एंड वन लिंक.
वन लिंक किसका है भाई?
राजीव अग्रवाल का. बट डोंट डाउनलोड इट. आई एम गिविंग यू अ रिवाइज वन.
जल्दी दे दो.
हाँ बस अपलोड ही कर रही हूँ सर.
ठीक है, मैं इंट्रोडक्शन का ये डोर बंद कर दो थोड़ा. Dr. Sameer is already there.
Yeah, good evening, sir.
Yes, sir. Is there?
Shardul, sir, can you lower? Yeah, now your view is perfect, sir. Perfect. Yes. Shardul?
Work is, sir, actually it is sending very less signal, so we may feel a break in the video.
Sir, that day your signal was good. Are you near to the router, Dr. Sameer?
Yes,
Same location or change the location, sir?
same location.
Okay. Wi-Fi पे है ना, sir?
Wi-Fi.
Okay. Can you just share your presentation quickly, sir?
Now it's coming okay.
हाँ. शेयर एक बार प्रेजेंटेशन क्विकली शेयर कर लेते हैं सर. सर नेक्स्ट टू द माइक आई कैन शेयर स्क्रीन इज देयर.
Just doing it.
या प्लीज. हाउ इज द वॉइस, शार्दुल?
सर का वॉइस ओके है.
ठीक है, ग्रेट. तो वॉइस इज डन, वीडियो ठीक है. नाउ लेट्स सी द प्रेजेंटेशन. Perfect, sir. Resistant hypertension. If you can just take it onto the slide. Yeah, perfect. Run couple of slides, sir. Good, sir. Sir, only one thing, in case if the slide gets stuck up in between, let's not panic. Just do the right click and click on the next button. The slide will start moving.
Right click means?
Sir, mouse पे right click करके next कर दीजिए. Yes, that's what I'm telling. Sometimes due to processor of the computer, na. Sometimes it goes slow. That's why. Any video?
No video.
सर जब अटकेगा तभी करिए, अदरवाइज तो डाउन एरो से परफेक्ट जाएगा आपका पीपीटी.
ठीक है?
या डन सर. डन. यू कैन एंड द stop you can do it. And अगर सर वाईफाई वीक हुआ बीच में, मुझे ऐसा लगा, तो आई विल पुट a message to you in the chat box. On the top, can you see On the top right, next to people, there is a chat box. I am just putting a message there. Hi, Dr. Samir. So like this, I'll put that signal is going weak. So maybe if you have some extra mobile, which is not used much, then maybe you can take it as a hotspot. 4G signals are always good, provided mobile is getting good signals. And will you like to add doctor before your name? Because it is only displayed as Samir Kuba.
So how do I do that? Do I again log in?
Yes, sir. Go on to the people. On your name, Samir ke upar, you just take the arrow and click it. The box will open up. You can do the relevant changes, and outside you can click anywhere. It will get saved.
Okay now?
Yeah, perfect, Dr. Samir. Yes, perfect. Perfect, sir. Great. So you're all set, sir. We are waiting for other doctors to join so that we can just do testing. Johnny, sir.
If there's an internet issue, then I need to go to the hotspot.
या सर अभी वैसे आपका वीडियो ठीक आ रहा है, बीच बीच में कभी स्टक हो रहा है. अभी आपका वीडियो देखिए फिर चला गया, 0 हो गया था, फिर 160-90, फिर 0 हुआ. तो आइदर आप सर वाईफाई राउटर के पास अगर बैठेंगे तो इट विल बी बेटर, और इफ यू हैव सम हॉटस्पॉट इट विल बी गुड, क्योंकि ये आ रहा है जा रहा है तो बीच में ड्रॉप हो रहा है आपका सेंडिंग. अगर आप पीपल पे है ना सर, तो आप कॉल डिटेल्स के डाउन एरो पे क्लिक करके देख सकते हैं. आप अपने नेम के आगे जो एरो है फॉरवर्ड, उसको क्लिक करेंगे तो नीचे कॉल डिटेल ओपन हो जाता है. तो कॉल डिटेल्स में आप देखेंगे तो आपका सेंडिंग 160-90 दिखा रहा है, विच इज एक्चुअली द लोएस्ट. इसलिए आपका वीडियो अटक रहा है बीच बीच में. इट शुड बी मिनिमम 320, आइडियल इज 640.
Actually, I do most, I mean, in 3-4 days, there's some meeting, I do it from this side only, and I have faced a problem except.
Sir, Wi-Fi is actually not in our control. It is all in the air, the number of users logged in. So from the same location on the testing day, it was coming excellent. Today, maybe the people in the locality and whatever is the mobile network, it all depends upon many factors. You know?
Okay, so if I go to hotspot, then I just click this hotspot,
Just you can, yeah, Shardul, tell.
Sir, I think better if you have time, you can check hotspot because sometimes audio is also a little bit breaking. For Dr. Kuba.
So I disconnect my Wi-Fi and connect to the.
Please do that, sir. We'll check with that network as well.
Poonam ji, where are the other doctors? Only 6 minutes are left, madam.
Sir, good evening.
Yeah, Dr. Raj. Hi. Good evening, sir.
गुड इवनिंग. गुड इवनिंग.
Yes, sir.
Recording has started.
बिल्कुल बढ़िया डॉक्टर साहब, मेरा 5 मिनट में वेब नहीं, इस वक्त नहीं हो, आप जो भी है जल्दी बता दें, क्योंकि मैं एक वेबिनार में मेरे को 3:30 बजे 7:30 बजे लेक्चर देना है. 5 मिनट है बस. किसके?
हेलो
आप
संदीप जी.
कल आ जाए 3:30.
I'll just mute Dr. Rajiv.
हेलो
one second.
संदीप जी.
Yeah, tell me.
Dr. Iyengar is come and Dr. Ziver is also.
Yeah. We are seeing.
Hello. Yes. I am there. I am seeing everybody. Rajiv. Okay.
Sir, good evening.
Good evening.
Sir, good evening, sir. Vijay.
Right. Thank you.
Good evening, sir. I have sent that link.
Okay, but I got it.
Okay, sir. Dr. Iyengar, sir, myself Vijay.
Vijay, we have less time. We will just take on doctor. You can switch off the camera and
I will leave
board.
it, sir. I will leave the meeting.
Yeah.
Thanks.
So we will start with Dr. Iyengar and Dr. Rajiv is also there. Doctor,
Close and start it.
yeah.
Please hold on.
Shardul, can you switch off the mic, mute all the mics except Dr. Rajiv's mic? We will first do Dr. Rajiv's. Sir, as promised, your signals are coming good as of now. And can you quickly share your presentation, Dr. Rajiv?
I have, okay, now.
Yeah, we will just a quick testing we are doing, sir, in terms of voice, presentation and everything, sir. You can minimize this, sir. Yeah, LDL aspiration.
Yeah, just a minute. I have to come on the screen.
तो minimize कर दीजिए उसको.
No, sir.
No, sir.
So you just need to share the screen again and minimize this. Yeah, I can see.
Yes.
We can see it.
LDL aspiration realism 2020. Sir, can you run few slides? Can you move on to the next slide, sir?
I'm trying, it is not moving.
So this is a common advice to all doctors, sir. Can you do a right click on the mouse and press the next button? It will start. Just click next. It will move.
Yes.
Next you have to click, sir. On the top. डॉक्टर राजीव सिर्फ राइट क्लिक करके नेक्स्ट कर दीजिए सर, नेक्स्ट स्लाइड चला जाएगा वो.
हाँ, right, that I am aware.
ओके, फेयर एनफ. अगर एक दो स्लाइड सर मूव कर देंगे, वी विल जस्ट चेक इट ऑल्सो. या ग्रेट सर. शार्दुल, वॉइस इज ओके एंड सिग्नल इज ओके?
Yeah, Dr. Rajiv, signals are okay. Sir, can you say one or two lines, please? एक बार check करते audio.
Good evening to everybody.
Great,
Good,
sir.
sir, good. No.
अच्छा आ रहा है. Now you can mute all
So
and
mute.
we will. And then the next presenter, Dr. Gaver. Dr. Gaver, you have the presentation also, sir.
Yes.
Dr.
Yes.
Rajiv, you can do stop.
Do you want me to share that?
Yes, please do it, sir. Please do it.
Okay. Can you?
LDL modifications in diabetes, Dr. Gaver.
Yes.
And
Yes.
yeah,
Yes.
just move on to the next slide.
Okay, I am moving. Okay. Now I think it's going smoothly. Okay, right.
Just click on the next and then it will move, and then you can use the down arrow.
Oh, yes, it's moving now. No problem.
Sir, on our screen, it is not coming. We are stuck only on the first slide, so I'm little worried on that. Is it moving on your computer?
Oh,
Shantanu?
nice. It is moving very well in my computer.
No,
Do you want
even
to
for
stop
me,
and-
it is first slide.
Yeah, sir, it is not changing. So can you just click on the next? It is stuck there, actually.
No, this is the next slide. Okay. Can you see now the next slide?
No, sir. Can you do stop sharing and do the share again, sir, please?
I will.
Yeah, now it is.
Yeah.
Yeah,
ठीक है.
maybe some time back. Sir, again, if you can share, it will be good.
I'm seeing the share button now.
Sir, next to mic, there is a share screen button.
Next to my mic.
On the top,
If you take
next to mic,
No, there used to be, but I think it is no longer there. I don't. Okay. Don't know.
You can click somewhere
Hello.
outside, it will show again on the top.
sir, can you see us on your screen? Oh, we are receiving the presentation. You're muted, sir.
can you unmute, sir? Dr. Giver, I think you have muted your mic. So just unmute the mic.
Unmute.
Yeah.
Yes.
Yes,
Okay.
yes,
Now it's
yes.
okay.
Yes, sir. Burden of DM in India.
Okay. Now I will move the next slide and see whether it
Yeah.
is coming. Okay.
Yeah. Yeah.
Right. Next slide.
I don't know. It's taking
Not
some
coming?
time. Not coming, sir. It should
Prevalence,
come
yeah,
now.
I got that. Prevalence of
Yeah, sir.
diabetes.
Now it is coming. Prevalence of diabetes in India.
Oh,
Yes,
right,
sir.
right.
No
Can we
problem.
move to the? Can I move to the next slide?
Yeah, please do it.
Okay.
I think
Yes,
we
sir.
are
It
like
is.
4-5 seconds back, sir, but it is fine. Increasing prevalence of DM, so we're
No
getting
problem.
it.
We are getting it, sir. You can do stop sharing. Now, if
Okay.
Dr. Anger is there, we can just start the meeting. Poonamji, Dr. Anger is not.
Just inform Dr. Iyengar that you will be sharing the introduction slides.
Madam, he is not onto the panel right now. His, I think, signal or some issue happened. He logged out.
Dr. Kuba, I think he has changed the network. Can we check it again?
Dr. Kuba, can you start your video, please? Dr. Sameer. Yeah, sir.
Am I audible? Am I audible?
You're audible, sir.
I have actually mobile hotspot. So I have gone to my mobile hotspot. So is the video okay now? Is the connectivity fine?
नहीं, Wi-Fi is better than hotspot. इसमें और अटक रहा है.
Sandeep ji,
madam.
Dr. Iyengar has some system problem. He's changing his system. He has asked to start with the introduction. He'll join in.
Madam, let him join by the mobile phone. Any which way, he is not having any presentation. Or share his
He's
number,
joining
I'll
in,
talk to
but
him.
then introduction he'll have to give now.
So what do you suggest? We start the meeting?
I think we can start the meeting and he can join and then moderate the session, because I don't think we should delay any further.
Johnny, sir?
There is a set of questions which as a moderator he can address to.
Okay.
Yeah,
right.
yeah.
I think that is the most important part.
Okay, sir. Okay. संदीप जी कभी लाइव है बता दीजिए accordingly we can take it.
Yes, yes. Just a second, sir. I am just sharing the PPT and
Sandeep sir, Dr. Kuba, this the Wi-Fi network was better than this mobile network. इसमें ज़्यादा अटक रहा है. There is voice also थोड़ा सा. Voice अटक रहा है सर इसमें. उसमें voice अच्छा आ रहा था.
We'll call him on phone and inform him.
I am just sharing my screen. So Dr. Rajiv, just don't share the screen, please. I am just taking over now screen share.
Yeah.
Sandeep sir, Wi-Fi network was better than.
Johnny, sir, you can start the meeting now.
Yeah.
And be brief about our introductions. That time should not be lost.
Yes, sir. Yes. So, good evening, doctors. It's indeed a great pleasure to welcome you all.
The mic is off, Johnny, sir.
Good evening, doctors. It's indeed a great pleasure to welcome you all this evening for this expert webinar series. Today we have an elite galaxy of speakers and the moderator today for our session. The topics are going to be quite interesting and of course going to be useful in the day-to-day practice. We at Ipca are delighted to have Dr. S.S. Iyengar to moderate the session for today. Sir has almost got 35 years of experience in the field of cardiology and has contributed immense to the field of cardiology, and he is associated with the Manipal Hospital, Bangalore, and quite a prominent figure amongst the medical fraternity, because any conferences, any meets, yes, sir always has his lucid presentations. And he is also has got the previous assignments, where is a physician to the Chief of Air Staff, Air Indian Force, New Delhi, and also a cardiologist in Command Air Force Hospital, Bangalore. He has also been the professor and head of cardiology at St. Medical College Hospital, Bangalore between 1995 to 2010. And Dr. Iyengar was also been awarded with the Vishishta Seva Medal by the President of India in the year 1982. He is also the member of Cardiology Society of India and a fellow of the Indian College of Cardiology. And he has got an immense 55 publications to his credit. So it's a great pleasure to have Dr. S.S. Iyengar to moderate the session today. And we have three speakers today to have different perspectives on the different topics. The first speaker is it's a great honor to introduce Dr. Rajiv Arwala. Of course, his contribution also in the field of cardiology has been immense. And he holds a doctorate in the field of cardiology from GB Pant Hospital, New Delhi. He chairs the Department of Cardiology at Jaswantram Specialty Hospital, Meerut. He works equally in preventive and invasive cardiology and enjoys taking diabetes, vascular diseases as areas of interest. So we always love to listen to him whenever we get an opportunity. So he has a deep interest in the vascular biology, especially in diabetes. This department is the biggest referral base for India for Boston Cardiac Foundation, which impacts the free pacemakers for needy people. And yes, another prominent recognition is he holds the Limca Book of Records for implanting maximum number of pacemakers in India. Dr. Rajiv Arwala also was awarded the Lifetime Achievement Award by the IMA Meerut, given by Mr. Siddharth Nath Singh, member of Health UP. And he also recently went to Adidas above a mission for implant-free pacemaker in the year 2017. Has been awarded the Lifetime Achievement Award in 2018. And yes, Inspiring Doctors of India Cardiology Award in 2018 by the Economic Times on Doctors' Day. And yes, Health Icons in Felicitating the Lifesavers by the Times of India. And Literacy Excellence Honor in 2018 by Bharat Nirman, an NGO. So a lot of credentials, a few which we have briefed now. And the next speaker for today is Dr. Jeevar Sakaria. Again, an eminent speaker in our country. Dr. Jeevar has accomplished his MBBS from the Calicut Medical College and was awarded the gold medal for being the best outstanding student. And he had his MD from Calicut Medical College and DM from the Premium Institute, the Sri Chitra Tirunal Institute of Trivandrum. He was the Chief of Cardiology of Amla Institute of Medical Sciences, another Premium Institute amongst the medical hospitals and colleges. And he was also the medical superintendent of Amala Medical Institute, Medical Sciences Institute. He was also Chief of Cardiology of the Mother Hospital. And he has been also instrumental as a former president of CSA Kerala chapter, former president of Trichure Cardiology Club. He was also the former president of Indian Academy of Echo Kerala chapter, President Society of Heart Failure and Transplantation, Joint Secretary CSA National Executive Committee, and convener of Preventive Council CSI between 2013-14 and 14-15. Also coordinator Scientific Committee CSI 2013. He has been also co-investigator for various trials like the pilot study of ACS, Kerala ACS registry, and coordinator and the co-investigator of CSI Kerala CRP study. Of course, sir has got many publications like CSA Kerala CRP study methodology and design published in the Indian Heart Journal, prevalence of CAD and its risk factors in Kerala published in BMC, cardiovascular, and again a Kerala ACS registry published in the European Journal of Cardiology. So with this, again a few more credentials, a few which we have briefed about sir's introduction. And we have another eminent cardiologist who is going to, for today as a third speaker, Dr. Sabir Kubba, who is an Associate Director of Clinical Intervention Cardiology, the Max Hospital, Vaishali. and he is also instrumental in initiating the primary angioplasty program in various hospitals in Delhi and NCR. Significant work on pharmaco-invasive management of STEMI in India, and again the paper published in JAPI for the same in May 2019. He was also faculty and speaker at various national and international forums. He was also special invited faculty of TCT Washington in 2014. Author of many publications in various national and international journals, and also contributed chapters in various books. He was also section editor for the 5-Minute Clinic Consult in 2020 Southeast Asia edition. Or national coordinator for the primary PCA register 2016, part of the expert panel of Lipid Association, for formulating consensus statement in dyslipidemia in Indian patients. Again, a part of the Indian consensus on hypertension guidance published in Medipulse International Medical Journal in 2019. So the galaxy of speakers and moderated by Dr. S.S. Iyengar. So with this, we request Dr. Arju Agarwala to have the first topic of discussion for today. Sir, over to you, sir. And the topic is LDL reduction, ambitions and achievements. Quite an interesting topic. Over to you, sir.
Opportunity to welcome you all to the symposium in the absence of Dr. Iyengar. I am grateful to Dr. Jeevar and Dr. Samir Kubba to consent for this evening webinar. I'm going to speak to you on LDL, statin, which is part of our life. Like we breathe, so is LDL and statin. So I'm not going to cover you everything related to that, but I'll give you some glimpses. What are our ambitions, aspiration, and how is the realistic issues in management of LDL. So it will be a run-through program for next 15 minutes. Most of the information you know, I'm trying to reorganize you the way I look at it. Just a minute. Everybody knows that when statins came, 1 millimole reduction of statin, that is about LDL, by statin causes 21% relative risk reduction of CVD. Once you do more statin, more aggressive, intensive lipid lowering, another 0.5 millimole, that means another 20 milligram, there is 16% reduction in relative risk. So if we combine two, that means 1.5 millimole reduction, what we say intensive lipid lowering, there is 33% relative risk reduction. So this is a trial data which has come out of CTT slope or a CTT analysis, that intensive statin therapy means more reduction in mortality and morbidity. This is just a 4-year analysis that if you have 100 or less than 10, 2.6 is roughly around 100, and this 0.26 means 10. You see such an aggressive lipid lowering which we achieved in 4-year trial. There is reduction in CV death, stroke, unstable angina, and coronary vascularization, as well as if we take 3-point MACE, CV death, MI, and stroke, still there is 41% relative risk reduction. So we are aiming for a very, very aggressive LDL reduction because it translates into reduction in mortality and morbidity. Just a minute. And this is what different trials can be plotted. And Improve It was the first trial which brought us down to a level of 50 milligram per deciliter. And on top of it, when 4-year trial was planned, when outcome was given, they reached up to 30 milligram per deciliter, and there were about 25% patients who were still lower than that. So 4-year was one trial, which was of course PCSK9 on top of statin, but it fulfilled our ambition of achieving ultra low level of LDL. And we came to an algorithm: high is bad, average is not good, lower is better, even lower is even better, and lowest is best. So over a period of time, we have come up to this understanding that lowest possible LDL level are the best LDL level achieved. I'm not able to move forward despite. Another study which is very close to my heart is an improved study where simvastatin 40 milligram and azitamib was given for long term means 7 years, and it was done in diabetic ACS patient. What it showed was that after 7 years, if you have a polyvascular disease with type 2 diabetes, then the relative risk reduction over a period of 7 years is 9.1%, which is number needed to treat is 11. And I hope you all guys read a lot of cardiology, and I'm not aware of any trial which gives you absolute risk reduction of 9.1%. But one message you have to carry home is that these are not routine patients. They are very high risk patients, and they are diabetics, and they have polyvascular. Polyvascular means when there are more than one vascular bed involved. So we were bringing in concept of the risk profile of a patient, that if the risk profile of the patient is high, then low level of LDL results in mortality reduction, like in IMPROVE-IT. Then naturally the obvious concern with many of you carry home is that when you do ultra low level of LDL, there is side effect profile is more. So let us do the Fourier study and patients who were less than 1.8, and these were the patients roughly around less than 70 milligram. And what we see in magenta color, you have 0.5. 0.5 means less than 10, and 2.6 is less than 100. 2.6 means less than around 100. So if you see that in these patients, in 4 quartiles, the risk profile in terms of side effects, adverse effect, discontinuation, new onset diabetes, cancer and cataract, there is p-value was not significant. That implies that in these patients, the risk is not related to LDL, the risk was related to the statin dosage. So one another big message is worried about ultra low level of LDL if you are using moderate intensity statin or moderate intensity with azitamib or statin with PCSK9, because the Abengos trial has shown that the cognition effects were not different in these PCSK9 driven studies. There was no difference. So the side effects were related to statin, not to the level of LDL. And the same thing is come out of IMPROVE-IT, where they have shown that the new signal for new onset hyperglycemia was not seen in IMPROVE-IT trial despite achieving 50 milligram deciliter of LDL. So, ladies and gentlemen, the side effects of lipid modification is not related to LDL level achieved. They are related to statin dosage. If you can manipulate a moderate intensity statin or a high intensity statin without side effect, and on top of it newer therapies, then probably you will not be facing the side effects which you are brought up with, that statins are associated with lot of side effects. Then coming to the synthesis of concept, what are the targets? These are European targets. That means if you have expressed ASCVD, either clinical or in imaging. Imaging means if you have CT angio, more than 50 to 60% of stenosis, carotid intima thickness more than 0.77, then these patients have imaging atherosclerosis. Then the LDL level achieved is 55, and if you have markedly elevated single risk factor, and these patients with familial hypercholesteremia, moderate CKD. CKD means 3A, 3B, between 30 to 60, diabetes without target organ damage, diabetes more than 10 years of duration and with additional risk factor, but these are not patients who have expressed atherosclerosis. Then the target is 70, and in moderate risk patient, the target is 100. So we have come to the conclusion very specifically that the target of LDL will be based on the baseline risk of the patient, and that is how we will chase the target. Higher the risk, lower is the LDL target. Another thing which has come out of it, that in ESC guidelines, if you have atherosclerosis, maintaining a LDL of 50, and if these patients throw an event within 2 years, then LDL 40, less than 40 may be another realistic goal, and the recommendation is to PB. Mind it, all these guidelines, they advise level something like less than 40, less than 70. They do not talk 70, 40. That means if you achieve lower than this, guidelines don't obstruct you. So if in a patient you achieve 30, you have not to step down the dose of the drug, because the guideline recommendation is less than 40. Then we have recent guidelines which were published by Lipid Association of India, and they were published in Journal of Clinical Lipidology, which is a journal of National Lipid Association of America. These are our own guidelines, and what we define a very high risk group, that means pre-existing diabetes, pre-existing atherosclerosis with diabetes, or homozygous hypercholesteremia, or these patients throwing an event within 1 year. Within 1 year. European guidelines, they say 2 years, we say 1 year, then we classify them as extreme high risk category, and in this patient population, we target the LDL to 30, which is the target achieved in 4-year trial. So I'll say the Lipid Association guidelines are a milestone ahead of rest of the world, because in a patient who is maintaining a LDL of 50, throws an event again, then the guideline recommend you should aim less than 30. If you achieve 25, you are better. If you achieve 20, you are better. You are not supposed to step down the regime of the drug. So this is just how we go about. You have to re-evaluate the lipid levels at 4 to 6 weeks. If they are not achieved on maximal tolerable doses, then azitamib, being a cheaper drug, should be displayed in every patient. The hypothesis comes very strong. All of you know the Goldstein and Brown. They were the person who identified the LDL receptor and was awarded Nobel Prize in 1985. And in their Nobel laureate speech, they said a plasma level of 25 milligram deciliter would be sufficient. So we took more than 35 years to understand that what these people, these scientists, projected and postulated at 25 milligram. It took us many decades. And we know that umbilical cord blood has got 30 to 70 milligram of deciliter. So nature is not unkind to us. In secondary prevention, we should chase and optimize our LDL level to something like 30. How low is low? Then this is again, Antonio Boto said that lower sweet point is 30. Another thing which is very important to understand is low is not important alone. How long? And the answer is, again by Brown and Goldstein, my slide showed you, they said longer is better. And this is the hypothesis, and now it is understanding that in LDL you achieve, it should be maintained lifelong. There is no concept that you achieved low level, now after 5 years you stop the drug. You have to achieve these levels lifelong, because atherosclerosis is a ever progressing disease which goes on lifelong. Then what I am trying to conceptualize is that this is the CTT curve. If you are moving from this point to this point, say roughly around axis of 100 and above, then the mortality reduction is very marked. But if you are moving on the left side of the curve, like improve it and 4 year, there is no mortality reduction. The event reduction is there because mortality in anyhow in these patients is low. So that is the only difference you have to carry home, that in ultra low level of LDL, the mortality reduction may not be the reality, but event reduction is a definite gain. There is Valentine Fuster postulated that 4 years was done for 1.8 years, 1.8 years. If it would have been done for 4 years, like majority of the trial, then it could have shown mortality reduction, because the trial was for a very short duration of time. And that is how we look at it. Earlier you intervene, you shift the curve to the right, and that is how we intend to do in life, that we intervene our patients very, very early. It is very easy to intervene patients who are in secondary prevention, or patients who are heterozygous or homozygous familial hypercholesteremia, but it is very difficult when you think of community intervention in terms of primary prevention. That is a challenge, but it is a reality that if you lower the intervention, start intervention at 30 years, you shift the curve and you will gain this much of life. So that is upcoming thing, that how to intervene early so that the morbidity and mortality of atherosclerosis can be tamed. This is a very interesting slide, and I'm going to show you that how we look at it. This is the Odyssey outcome, and what it shows, that if the 3 vascular beds are involved like this, then the NNT is 8. That means more generalized atherosclerosis, NNT is reduced. Look what happens if there are 2 vascular beds involved, then the NNT is 52. If there is only 1 vascular bed is involved, NNT is 71. So ladies and gentlemen, if you do aggressive LDL lowering, you will reduce mortality, you will have very low NNT in case the background risk is very high. But if the background risk is low, then probably your NNT will be high, and you will have more NNT and more event reduction than mortality reduction. So again, even the Odyssey outcome shows that the background risk is very important determinant, and it translates into mortality benefit if you achieve low LDL in these patients. So again, showing the same thing, same amount of LDL reduction, 25, 25, 25, the risk reduction keeps on decreasing because the risk is low in these patients. So absolute risk is very important determinant in translating mortality reduction in aggressive lipid lowering. I want to say that many of us will argue out that since there is only event reduction, no mortality benefit, I am not keen. So I'll put forward 2 simple things. This is a publication from JAMA. When aspirin, clopidogrel is added with aspirin, it never showed cardiovascular mortality reduction, never showed total mortality reduction. It only showed event reduction. And you know, clopidogrel is part of our life in acute coronary syndrome. It never reduced mortality. So ladies and gentlemen, event reduction is also a very big thing. And I famously reminded of a very jovial remark that wrist injury when you correct a wrist injury, it does not translate into mortality reduction. So let us not do it, because there is no mortality benefit. So that is a very crude endpoint. So ladies and gentlemen, I'll suggest that event reduction is also very important when you are working at ultra low level of LDL. The last few slides, that LDL is LDL. Don't be obsessed that LDL achieved by statin because of pleiotropic effect is better than the LDL achieved by superior than LDL achieved by ezetimibe. No. Whatever way you reduce LDL, the benefits will be proportionate to LDL level, not the method. Unlike diabetic therapy, where if you use SGLT and GLP-1, your outcome is different than the other drugs. In lipidology, LDL is a simple molecule, is homogeneous, is not like heterogeneous mystical molecule like HDL. Whatever way you reduce LDL, whatever level you achieve,
you will get the benefit according to the level. So it is not like diabetic management that SGLT2 and GLP-1 are superior than anti-diabetic. Anyway, ezetimibe, statin, PCSK9, bempedoic acid, whatever you do, inclisiran, everything is same. So this is, I am trying to show, even bariatric surgery, the mortality benefits are same, all cause macrovascular disease, coronary artery disease, the cerebrovascular event, all cause mortality, and time zone, if you see over a period of time, they are more or less plateau-like. So again, one thing I am trying to emphasize, in diabetic overweight patient, especially if the BMI is more than 35, it is class 1A indication for bariatric surgery. Practice it because it is going to transform the life of an individual. If it is BMI 30, it is class 1B. So practice bariatric surgery because it translates into total reform in the patient profile. It is not a cosmetic surgery. It is a metabolic surgery which translates into advantage. This is just giving you power that this is a slide from NEJM. This is a patient, stable coronary artery disease, having ischemia, treated with statin and guideline-directed therapy. The myocardial perfusion scan after therapy is negative. So this is something you can regress atherosclerosis. That is what is our aim. And this is one patient I am showing. This is February 15. This is my patient, had left main disease, 32-year-old, went CABG, was given AICD, came back to me in 1.5 years with ulcerated lesion of RCA, and we had to fix it again. And you know, the problem was the homozygous hypercholesteremia was not identified, heterozygous hypercholesteremia was not identified. Patient was stuck to the surgeon and a cardiologist probably who was not oriented and maintaining a LDL of 90 over a period of time. And that is an error of commission, that this patient came back to us with right coronary artery disease, having CABG and AICD. So don't get misguided that these are the therapies. No, atherosclerosis can only be tamed by LDL modification at this time. This is inclisiran, which is a wonderful drug, and Dr. Braunwald's slide, which he showed in Munich, that how he sees atherosclerosis over a period of time, and he says, maybe we intervene at a patient who is just having a LDL of 105 or 110, use inclisiran twice a year, and may add 30 years of his life. That is our ambition. That is our aspiration, that we intervene so early in life that we increase productive 30 years to these individuals. And I'm not talking of people who are hetero and homozygous. These are the people of community, because atherosclerosis is the biggest curse of the mankind in modern days. And this is Braunwald saying, simplifying everything, that atherosclerotic CV disease remains the #1 cause of death and disability in adults. Elevated LDL-C is the most important risk factor. Do not worry about the side effects. They are very, very infrequent. What level of LDL should we aim for? Lower the better. Lower the better, but without side effects. And these are the cocktails of drugs available to you and to me. And mind it, that different combination can fulfill our dream of achieving the ultra low level of LDL, PCSK9, inclisiran, bempedoic acid, icosapent, ethyl. These are the drugs which can be added on to statin and ezetimibe to modify the lipid, the atherogenic lipid profile. Ladies and gentlemen, we are not artery cleaners. We are artery healers. We have to heal the arteries. So be charged, be motivated to modify the lipids so that we can reverse atherosclerosis. Just to show you a couple of good slides. This is Michelangelo, Last Supper, Jesus Christ having a dinner, and probably what it looked like in Corona times. So just on a lighter note, I must thank Dr. Iyengar to give me this opportunity that I could communicate and express myself and passion of LDL lowering in times so that we can repair our necks we can better do community service in times to come. Thank you very much, Dr. Iyengar.
Thank you, Dr. Rajiv. You can hear me?
Yes, I can hear you.
Dr. Rajiv, can you hear me?
Yes, I'm hearing
Sorry,
you.
I missed the opportunity.
No problem, sir.
I missed the opportunity and a pleasant job of introducing Dr. Rajiv, excellent speaker and excellent cardiologist with a lot of charity work. And he has told us briefly how aggressive you should be in LDL cholesterol lowering in people who have got high ASCVD risk. He has told us that lower is better. Earlier you start lowering it is better. Longer is better. And he also told us that don't always be worried about mortality. Look at morbidity also. Because person stuck down stroke or stuck down with MI and heart failure is not leading a good life. And they also told us about it is not important that you use only statin to bring down cholesterol. What is important is bring down cholesterol by any means. So earlier days we used to talk of statin hypothesis, that is gone. But we talk nowadays the cholesterol hypothesis. So we must bring down cholesterol by all means, starting with lifestyle measures, statins, ezetimibe, and PCSK9 inhibitors. And it has told us that we can produce regression of atherosclerosis. He has shown it with his own experience and by various slides. Thank you, Dr. Rajiv.
Thank you, sir.
Excellent presentation. Should you go on to the next topic?
Yes.
Take the questions.
Yes, sir. Sir, we will go to the next
topic. Yeah, it is my pleasure to introduce Dr. Jiva Zakaria, who did his graduation from Kerala. Is a gold medalist there. Did his MD in again Kerala, DM from Chitra Institute. The Chief of Cardiology at Kamala Institute of Medical Sciences, became medical superintendent there, and Chief of Cardiology at Mother Hospital in 1992 onwards. He has been instrumental in many of the Cardiological Society works, former president of CSI Kerala chapter, then former president of Indian Academy of Echo Kerala chapter, president of Heart Failure Transplantation Society, joint secretary of the National CSI Executive Committee, co-investigator of many trials which come out from Kerala, which has put us on India on the international map. So he's going to talk to us presentation on LDL modifications in diabetes. Dr. Jiva, it is my pleasure to hand over the mic to you.
Can you hear me,
Yes.
Iyengar?
Yes.
Oh,
Yes,
I see.
yes.
Thank you, Dr. Iyengar, for your nice words, and thank you, Rajiv, because I always am fascinated when listening to you, and your passion for LDL lowering always has impressed me, and whenever you talk about it, I think there is a lot of excitement. So thank you, and it's very difficult to follow after a talk by Rajiv Agarwal, but I will try. Now my job here is to talk about LDL modification in diabetes, and as you can see that India has a huge burden of diabetes in the global burden of disease study, where they compared the prevalence of diabetes from 1990 to 2016 across all states of India, and the states were grouped into the level of epidemiological transition. And what they found was the number of people with diabetes in India increased from 26 million in 1990 to 65 million and in 2016. And this number is actually increasing because their prevalence rate was 5.5% in 1990 to 7.7% in 2016. But the prevalence was highest in Tamil Nadu, Kerala and Delhi. And a lot of people believe that this prevalence of 7.7% is maybe in a lower estimate because many of the studies from other parts of India has shown that the prevalence is much higher. For example, the CSI Kerala CRP study which we did in 2011 and it shows that across the Kerala state, urban, rural, the prevalence of diabetes was around 15%, and that is same replicated in many studies from South India. So if you extrapolate, the projected population of India is 135 crore in 2020, and the adult population will be around 81 crore. And assume the prevalence of diabetes around 10%, there will be 8.1 or 80 million patients with diabetes, a huge number in India. And this 10-year cardiovascular disease rate in this population is going to be 20%. But an annual incidence of CVD events, about 16 lakh people with diabetic must be developing a CV event in India. And knowing that statins and LDL lowering can reduce cardiovascular disease events by around 40%, like 13% for each 40 milligram reduction in LDL cholesterol. So the coronary cardiovascular disease events which can be avoided if all our patients with diabetes with a high risk are on statin, we can save 6.4 lakhs cardiovascular events. That's a huge number. But unfortunately, the prescription rate for type 2 diabetes in statin prescription in type 2 diabetes in India has been very, very, very low rather. A study by Rajiv Gupta, they did a multi-site registry based upon among internists, diabetologists and endocrinologists to determine the prescriptions of statins in patients with diabetes. And what they found was the statins were prescribed in only 55% of patients. That's prescription rate. And the statin prescription was higher among diabetologists, but see that endocrinologists are not prescribing as much statin in their patients, and statin prescription was lower in women. And interestingly, the high intensity statin, which has been recommended in high risk group of patients with diabetes, only 15% or less than 15% of patients prescribed statin. This is about prescription pattern. But when the prescription is only less than 15%, what about the compliance and the statin use in the secondary prevention trial? This is not about diabetic population. The Salim Yusuf paper in 2011, the pure data, showed that the lower middle income country where India belongs, the urban and rural, the statin use after say a cardiovascular event or a stroke event is only around 4%. So the 4%, even the prescription rate is low already, 55% only prescription by diabetologists, endocrinologists, but our patients are not even taking that. They are taking only 4%. So the huge number, 90-95% of our diabetic population, they are not getting the proper LDL cholesterol lowering treatment, which Rajiv Agarwal has been talking about. So diabetic dyslipidemia classically is characterized by the increased triglyceride, a decreased HDL cholesterol, and either LDL cholesterol is unchanged or it's slightly increased. The lipid abnormalities in diabetes can be basically divided into those in type 1 diabetes where the lipid profile is similar to controls if the glycemic control is good. Or in type 2 diabetes, you find increased triglyceride, VLDL, IDL, non-HDL cholesterol, and decreased HDL cholesterol, normal LDL cholesterol, but increased small dense LDL and LDL particle number and apolipoprotein B. However, when the glycemic control is poor, in addition to this increased triglyceride, VLDL, IDL and decreased HDL cholesterol, you find a modest increase in LDL cholesterol as well, with increase in the small dense LDL and LDL particle number. Lipoprotein little a levels are usually within the normal range in patients with type 2 diabetes and do not appear to be greatly affected by glycemic control. So it's clear that optimal glycemic control is also important to have beneficial effects on the lipid levels. But taking alone the LDL cholesterol level, people have found that around 65% of diabetic patients have an LDL cholesterol more than 100 and 35% less than 100. But what is the pathogenesis of this diabetic dyslipidemia? The basic pathogenesis of diabetic dyslipidemia is overproduction of the VLDL from the liver, leading to increase in serum triglyceride levels. Now, VLDL production is actually related to the triglyceride availability, which is determined by the availability of the fatty acids. Triglyceride prevents the degradation of ApoB100, which is a part of the lipoprotein, which allows the increased production of, that is one cause of increased production of VLDL. But basic cause for increased production of VLDL by the liver is more fatty acids come into the liver. Why more fatty acids come into the liver in diabetes? There is increased flux of the fatty acid from the adipose tissue due to increased fat mass, because most diabetes are adipose, obese. Secondly, the insulin suppresses the lipolysis. But in its absence, lipolysis is increased and fatty acid is delivered to the liver. Secondly, there is a de novo fatty acid synthesis from the glucose in liver. The glucose can be a transcription factor which stimulates enzyme required for fatty acid synthesis. And thirdly, there is increased uptake of triglyceride-rich lipoproteins by the liver in diabetes. So all this causes increased fatty acid entry into the liver, and coupled with that, the insulin stimulates the degradation of the ApoB100, and that so that in the absence of insulin, ApoB100 remains longer time and in the higher concentration in the liver. That will be incorporated to the triglyceride, and that is one cause of production of increased VLDL. And there is another cause is the ApoC3 expression is suppressed by glucose, and that is stimulated by insulin. So increased hyperglycemia suppress the ApoC3 expression, so they decrease the activity of the lipoprotein lipase. The effects of all this increased VLDL production from the liver is increased the CETP, cholesterol receptor transfer protein mediated exchange of this triglyceride from the triglyceride rich VLDL, that is VLDL, to LDL and HDL, which increases the triglyceride content of the LDL and VLDL. And this triglyceride content, which the newly acquired by the LDL and HDL, actually then hydrolyzed by hepatic lipase and lipoprotein lipase, and this leads to formation of small dense LDL and small HDL. And hepatic lipase is also increased in diabetes. So affinity of ApoA1 to small HDL particle is reduced actually, but small HDL, the ApoA1 is reduced. So that leads to the dissociation of ApoA1, which is a part of the lipoprotein of HDL, and which is easily cleared by the kidneys. And synthesis of ApoA1 is also reduced in diabetes. The net result is lower levels of ApoA1 and HDL cholesterol level decreases. And poor diabetic control. When the diabetic control is poor, the insulin activity is low, the lipoprotein lipase activity is low, and metabolism of rich lipoprotein is impaired. And so, if synthesis of new LDL is increased sufficiently, the LDL levels will also start increasing. But improvement in glycemic control can lower serum triglyceride, increase HDL, and decrease LDL. And this is what in net effect what we have shown, that is the liver has produced more VLDL, and this VLDL entered into circulation. Then the cholesterol ester transfer protein transferred the triglyceride to HDL and then LDL, and then the triglyceride will be hydrolyzed by lipases, so that the formation of small LDL and small HDL, and that is why the HDL level comes down. So the small dense LDL increase susceptibility to oxidation, increase vascular permeability, and conformational changes in the ApoB, decrease affinity for LDL receptor. So all this it can lead to cardiovascular events. The glucose lowering drugs we use for diabetes, that also has effect in the lipid profile. Insulin sulfonylureas, maglutationase, DPP4 inhibitors, and alpha glucose inhibitors, they don't have any effect on fasting lipid profile other than by improving glucose control. However, metformin, thiazolidinediones, GLP-1 agonist, and SGLT2 inhibitors, they have effects on lipid profile independent of glycemic control. Metformin actually decreases triglyceride, modestly decreases LDL cholesterol without altering HDL cholesterol. Thiazolidinediones, rosiglitazone actually increase the LDL cholesterol. Pioglitazone has less effect on LDL cholesterol, but increases HDL cholesterol and decreases serum triglyceride, and decrease in small dense LDL and increase in the large buoyant LDL. SGL inhibitors, small increase in LDL cholesterol and HDL cholesterol, and GLP receptor agonists affect the lipid profile by weight loss, which help in decreasing the triglyceride and increasing the HDL cholesterol. But the impact of all this lipid abnormality has already been shown. The increase of the coronary event, death, MI, and stroke. And how to modify the lipid abnormalities in seen in diabetes. You have all this lifestyle modification. But one thing which I want to tell you is about the dietary cholesterol. Normally, we have been talking about dietary cholesterol, restrict the dietary cholesterol, but there has been now thinking that dietary cholesterol as such in the form of an egg may not increase the LDL cholesterol that much, but not in patients with diabetes. The meta-analysis has shown that in people with diabetes, they are sensitive to the cholesterol in the diet, especially eggs. And diabetes behave differently. Because most cholesterol absorption in the intestine is not from diet, but the hepatobiliary sources. And in diabetics, there is an increase in Niemann-Pick-like protein and non-microsomal transfer protein. So there is increased intestinal absorption in diabetes. So that is why in IMPROVE-IT trial, which Rajiv has quoted, there was a pronounced beneficial effect with ezetimibe, which is a drug which inhibits the intestinal absorption of cholesterol. So in diabetes, it can be expected that ezetimibe will be more beneficial. And dietary cholesterol should be avoided in patients with diabetes. Now we have a lot of lipid lowering therapy which has already been alluded to, but statins stand out because the percentage of LDL cholesterol reduction that statins can do is enormous. And among the statins, rosuvastatin has 60% reduction in LDL cholesterol and similar magnitude is at high dose atorvastatin. A lot of trials, like combination of clinical trials where diabetes were involved, has shown that the aggressive lipid lowering reduced the primary event rate. And the meta-analysis of around 18,000 patients with the 14 randomized controlled trials and with a mean follow-up 4.3 years, a 9% reduction in all-cause mortality and 13% reduction in vascular mortality, or each millimole or 39 milligram deciliter reduction in LDL cholesterol. So if a patient start with the 240 milligram LDL cholesterol, 240 milligram cholesterol and 200 milligram LDL cholesterol, and you reduce to 100 milligram, you can expect a 40% reduction in the vascular mortality. And statins benefit, this is a chart where how does the statin inhibit the cholesterol synthesis, and it will reduce the LDL cholesterol oxidation also. So the benefit of statin is seen across all LDL levels, as has been explained by Dr. Rajiv, that even if the LDL baseline LDL cholesterol is 90 to 130 or even 50 to 90, the beneficial effects persist. And the cholesterol treatment trial is collaborative. Statin reduces cardiovascular events in diabetes across type 1 diabetes, type 2 diabetes, men and women in all diabetes. The CARDS was a dedicated study to assess the effect of statin for primary prevention in diabetes. Around more than 3,000 patients, 40 to 75 years, no history of cardiovascular disease, diabetes plus one or more retinopathy, albuminuria, hypertension, or smoking. An intervention consists of 10 milligram atorvastatin versus placebo, and outcome was acute coronary syndrome, revascularization, stroke. And they found significant benefit of the primary endpoint of death and stroke in as well as acute coronary event, coronary revascularization, secondary endpoints. And the heart protection study also, a similar study where a lot of diabetes patients were involved, and the study also showed significant event reduction. So what if baseline LDL cholesterol is only less than 2, which already has been answered by With CARDS and HPS, the subgroups that started with the lower baseline LDL cholesterol still benefited to the same degree as a whole population. So if the patient qualifies for statin therapy based on the algorithm, use the statin regardless of the baseline LDL cholesterol and then target the LDL cholesterol to reduction of more than 50%. Statin can be used actually in fatty liver and non-alcoholic fatty liver disease. There has been a concern because already in the baseline the enzymes are elevated. People were very reluctant initially to start statin, but even this subgroup of patients has been found that statins may improve liver enzyme paradoxically and also improve the histology in non-alcoholic fatty liver disease. So what does the guidelines say? There are a lot of guidelines now coming out, and I think the ADA guidelines is Rajiv has talked about the National Lipid Association guidelines, which I don't want to talk about now. Diabetes in all ages with the ASCVD or 10-year age risk more than 20%, definitely they should receive high intensity statin. Diabetes less than 40 years with the ASCVD risk factors, moderate intensity statin. Diabetes 40 to 75 years, even if they have no ASCVD, no risk factors, they should receive moderate intensity statin. And the ASCVD risk factors they narrated are LDL cholesterol more than 100, high blood pressure, smoking, CKD, albuminuria, and family history of premature cardiovascular disease. And ADA guidelines also mention that diabetes with multiple ASCVD risk factors, you should use high intensity statin. Diabetes ASCVD, the LDL is more than 70, despite adequate dose of statin, you should consider adding acetamide or PCSK9 inhibitors. And the diabetes age more than 75 years, you should think about moderate intensity statin after evaluating risk-benefit profile. So regarding the triglyceride level, if the fasting triglyceride is more than 500 only, evaluate secondary causes and consider triglyceride lowering treatment. If fasting triglyceride is 175 to 499, lifestyle, address secondary factors, but don't try to lower it by fibrate. The low HDL and high triglyceride most prevalent pattern in diabetes, but evidence for benefit of drugs is lacking. Combination of statin and fibrate associated with the increased risk of elevated liver enzymes, myositis and rhabdomyolysis, and not shown to improve cardiovascular outcomes. The ACCHA 2018 guidelines almost the same as the 2000 ADA guidelines. At 40 to 75 years, without ASCVD, moderate intensity. If it is ASCVD or high ASCVD risk factors, high intensity. More than 75, consider the risk benefit and then start moderate intensity statin. Regarding the young stage, between 20 to 39 years, with diabetes, either long duration or if they have albuminuria or an eGFR less than 60, or retinopathy, neuropathy, it is reasonable to start statin. And the ESA guidelines, as this diagram has already been shown, that it is a very high risk if you have diabetes and target organ damage and more than 3 major risk factors, and high risk if you have diabetes without target organ damage with diabetic duration more than 10 years or other additional risk factor, and moderate risk if the diabetes less than 50 years with diabetic duration less than 10 years without other risk factors. And the treatment and target vary according to the risk factor. So the ESC dyslipidemia guideline says that in diabetes at very high risk, LDL cholesterol reduction more than 50% from baseline, and LDL cholesterol goal should be less than 55 milligram per deciliter. In diabetes at high risk, an LDL cholesterol reduction of more than 50% from baseline, and LDL goal should be less than 70 milligram. And statins for patients with diabetes who are at very high or high risk, there is no doubt about it. And consider intensification of statin therapy before introduction of combination therapy, and if goal not reached, add acetamide. And type 1 diabetes also, if the diabetes less than 30 years with evidence of end organ damage and on LDL cholesterol level more than 100, consider statin treatment. The Lipid Association of India in 2016, Dr. Iyengar was the principal author. They divided diabetic patients with very high risk, diabetes with evidence of endocrine damage, and diabetes with more than or equal to 2 other ASCVD risk factors, and high risk diabetes with less than 2 risk factors and no end organ damage. There's only 2 category in diabetes in the Lipid Association of India category. And then they said that very high risk patients should have the LDL goal of less than 50, and the high risk patients with diabetes should have an LDL goal of less than 70. So they should be congratulated because they were the first society to recommend the LDL target less than 50 at the time when the ACC guideline and ESC guideline were seeking to either high intensity statin or LDL target of less than 70 only. So Lipid Association of India guidelines came out with that. Then the American Association of Clinical Endocrinologists and American College of Endocrinologists, they had grouped extreme risk category, diabetes with established clinical cardiovascular disease. Again, they brought down the target to 55, and now Rajiv Agarwal is talking about an LDL target of less than 30 in the new lipid guidelines. So to summarize, ladies and gentlemen, 65 to 80 million people with diabetes in India. The low prescription rate of statins, even in higher risk group of diabetes in India, is very surprising. And the compliance rate of statin in diabetes is very low, and probably based on pure is around, must be around 4%. The LDL abnormality, especially small dense LDL, are profound in diabetes, leading to atherosclerosis risk. Statins have better LDL lowering action and proven to reduce cardiovascular events in diabetes. Statin increases LDL receptors, LDL clearance, and reduce LDL oxidation to lower. So addition of other agents like ezetimibe to statins help further to reduce LDL levels in diabetes. All international guidelines recommend moderate intensity to high intensity statin in patients with diabetes. Combination of statins with fibrate should be given with caution. Thank you.
Thank you, Dr. Jira, for that excellent presentation. You told us the prevalence of diabetes is increasing in our country. Means people are becoming sweeter and fatter probably. And you have clearly explained the pathogenesis of dyslipidemia in diabetes and how, apart from lifestyle modification and effective treatment of the diabetes, the lipid lowering will help in reducing the mortality and morbidity in these patients. Thank you very much, Dr. Jiva. Should we go on to the next speaker?
Yes.
Again, great pleasure in introducing Dr. Samir Kuba, who is Associate Director, Clinical and Interventional Cardiology, Max Hospital, Vaishali, Delhi, NCR, and Director of Mohan Heart Care, Mayur Vihar, Delhi. He has initiated most of these angioplasty programs in various hospitals in Delhi. He has done a lot of work on pharmacoinvasive management of STEMI and published paper in JAPI. And he has been an invited faculty at the CT Washington, author of many publications in national and international journals, section editor of Cardiovascular Sciences in Southeast Asia edition, national coordinator for the primary PCR registry, and part of the India Consensus on Hypertension Guidance, published in MedFirst International Medical Journal in July 2019. And we are shifting the gear now. We're going to talk about the important risk factor for ASCVD, that is hypertension, and he is going to specially address the resistant hypertension population. Dr. Samir.
Thank you very much, Dr. Iyengar, Dr. Agarwal, and Dr. Zakaria. Am I audible?
Yes, sir.
Am I audible?
Yes, sir, audible.
Audible. Okay. So let me now take you to a different phase of the management of cardiovascular disease. Definitely LDL and lipids form the cornerstone. I would say the other cornerstone is blood pressure, because cardiovascular disease is a multifactorial disease and we need a multi-pronged approach for that. So, what do we mean by resistant hypertension? So it is defined as a blood pressure that remains elevated above the goal. I've highlighted the word above goal because the goal might be different for different individuals. With the concurrent use of 3 antihypertensive agents of different classes, most commonly this includes a long-acting calcium channel blocker, ACE inhibitor or an ARB, and a diuretic. In fact, all these agents should be administered at maximum or maximally tolerated doses at the appropriate dosing frequency. So if your patient doesn't achieve a goal with 3 drugs of these classes, classify him as resistant hypertension. There is another entity known as controlled resistant hypertension, which basically includes patients who achieve their target BP but do so only with 4 or more than 4 antihypertensive agents. Now, the prevalence of resistant hypertension in various studies is somewhere between 9 to 18%. And before we label a patient as resistant hypertension, we must rule out certain factors which we call as pseudo-resistance, and that is what I would discuss in the next part of my presentation. But let me tell you, these are some of the patient characteristics you must look at when you suspect resistant hypertension. Most of these patients are elderly. They may have multiple comorbidities in the form of arthritis, connective tissue disorders, malignancies, and many other comorbidities. These patients are usually obese, and obesity and hypertension have a link, and obesity-related hypertension has to be treated differently. Many of these patients will have evidence of target organ damage in the form of left ventricular hypertrophy, albuminuria. So every hypertensive patient, every diabetic patient should be evaluated for microalbuminuria at the first visit. Many of these patients are diabetics, and now we have realized that the entity of obstructive sleep apnea as a major contributor, which is underdiagnosed, and in fact one of the major causes for difficult to control blood pressure or resistant hypertension. So this is a lady who is 48 years of age. She is obese with a BMI of 40, short height, typical Indian lady, was on arthritis management with NSAIDs, quite irregular with medications, and seeing her history and seeing her profile, I had to ask a leading question to her husband about the sleep apnea, because many times these patients will never come up with this history, and you actually have to tell them so that they understand that this might be one of the causes. And she had a typical history of excessive snoring at night with daytime somnolence. She was uncontrolled. We did a sleep study for her, which was actually showing significant obstructive sleep apnea. She also had an LVH on the electrocardiogram, and if you look at the echo, she had an evidence of LA enlargement, grade 1 LV diastolic dysfunction, LVH, and also mitral annular calcification of the posterior mitral leaflet. So these are some of the factors which predispose to premature atherosclerosis. These are some of the factors which signify that this patient already has a target organ damage. Now, why is resistant hypertension important? Because with difficult to control hypertension, persistently elevated blood pressure, there is a high risk of developing end-stage renal disease, ischemic heart event, heart failure, and in fact, with ambulatory blood pressure monitoring, it has been seen that almost 2-fold increased risk of CVD events occur in patients with true resistant hypertension. Now, before labeling a patient as a true resistant hypertension, we must rule out pseudo-resistant hypertension, which is more common and more prevalent in our clinical scenario. And these are some of the possible causes of pseudo-resistant hypertension. The most important cause is poor adherence to prescribed medication, which will include many factors like the education level of the patient, the convincing level of the practitioner, the amount of time you give to your patient, and many other factors involved as well. White coat effect is another factor. Your patient will have a high blood pressure in your office, will have a normal blood pressure at home. The BP measurement technique many times is faulty, and that is one of the causes of high blood pressure, which actually may not be so. And finally, clinical inertia resulting in inadequate dosage. And a lot of therapeutic inertia is there before escalating antihypertensive therapy, probably because of lack of time or maybe because of lack of knowledge. we might assume that a BP of 140 by 90 in this kind of a patient might be okay, but actually in long term, this might be detrimental. So this study actually showed that undertreatment was the most common cause for pseudo-resistant hypertension, and I've mentioned the other factors. Now, what are the barriers to adherence? The most common factor for resistant hypertension or pseudo-resistant hypertension would be patient who is poorly adherent, and these factors are both at the patient level and also at the clinician level. In fact, in US, about 50% of the patients will not be on their antihypertensive medication within first year. So you can imagine the status in India. And in fact, only 20% of the patients had very high adherence, and that too in clinical trials. And varied levels of non-adherence have been seen in patients taking their blood pressure medications, which may vary from as low as 7% to as high as 60%. Now, at patient level, there could be multiple comorbid conditions. Your patient might be taking many other drugs for their other concurrent illnesses, and you give them 2 or 3 antihypertensive agents, they may not take it. They may have a suboptimal health literacy. I have seen in my practice that if I am able to give time to my patient and tell them about the side effects of high blood pressure in the form of a stroke, an MI, end-stage renal disease, CKD, etc., they actually understand. And I feel in last few years, with a lot of development happening, a lot of education from the pharmaceutical companies, patients are now understanding the importance of maintaining an optimal blood pressure. There could be adherence issues at the level of the clinician, complex drugs regimens. Sometimes we prescribe 2 or 3 or 4 medications instead of giving a fixed dose combination. There could be communication barriers, which I think is the most important factor which must be addressed to as doctors. And at times we may have a lack of information about the adverse effects. There was a clinician who actually I was sitting with, and he received a call from an ophthalmologist who was talking about the drug moxonidine and about the blood pressure and the heart rate. And he said the heart rate of the patient is 48, and the patient is on these category of drugs, and one of them was moxonidine. So the clinician apparently said, don't worry, moxonidine doesn't cause a reduced heart rate. So sometimes we are not actually aware of the potential side effects. I am still reminded of a patient of mine who had a persistent lingering dry cough because of amlodipine. And this is a very, very rare side effect of amlodipine. And I stopped her ACE inhibitor and ARB, but she still complained of cough. She was an educated patient, and she was very clear that this is because of amlodipine, and this is around 10 years back. So we have to listen to our patients. We need to understand the rare side effects of these medications. And lastly, the provision of care by multiple providers. The patient may go to one healthcare provider, may go to another healthcare provider, may go to a cardiologist, then to a nephrologist, and then to a physician, and everybody will change the drugs. So these are some of the factors which are barriers to adherence which must be looked into. And these are some of the effective strategies for improving adherence to antihypertensive medications. Trying to use agents that are dosed once daily, use fixed dose combination agents. Know your patient. If your patient cannot afford costly medication, give him low cost and generic antihypertensives. And this is very, very important. You may have different category of patients you are catering to. You must understand the needs of each and every patient. And finally, the most important point which I feel is education, education, and education. Not only to the patient, but also to their families about the consequences of hypertension and the possible adverse effects of medications. White coat effect is a commonly observed phenomenon, especially in young individuals, in anxiety individuals, in ladies. And the clinical clue to a white coat effect are patients who develop hypotensive symptoms on initiation of antihypertensive therapy, and usually they will not have evidence of target organ damage. A typical example would be a 40-year-old young techie who comes to you with tachycardia. His blood pressure in your clinic is 140/90, and you start him on a medication. He complains of hypotensive effects at home. The easiest way is a home blood pressure monitoring. The best way is an ambulatory blood pressure monitoring to rule out a white coat effect. But ambulatory blood pressure monitoring may not be available always, might be slightly cumbersome. So we encourage lots and lots of home blood pressure monitoring, wherein we can rule out masked hypertension and also white coat effect. Inaccurate BP measurement is also a very, very important reason for the resistant or pseudo-resistant hypertension. And I think everybody is aware of the BP measurement technique which should be done. So I will skip this slide in the interest of time so that we have more time for discussion. Clinical inertia, again, is a major factor. And if you see, about 50% of the patients with uncontrolled on-treatment resistant hypertension identified in a community-based practice were prescribed an optimal antihypertensive regimen. So that means half of the patients were not given an optimal antihypertensive regimen. So that is one of the very, very major reasons, and we are responsible as doctors in actually improving that aspect of treatment. These are some of the drugs of which commonly used drugs like NSAIDs, antidepressants, steroids, sympathomimetic agents. These can increase the blood pressure and can cause resistant hypertension or difficult to control hypertension. History of oral contraceptives in females of childbearing age must be taken. Some patients would be on cancer chemotherapy like cyclosporine and tacrolimus. So appropriate drug history is very, very important, and I would say it would be a good idea to keep a list of these drugs handy on your table so that you can actually look at these drugs immediately while your patient comes to you, and you can rule out that some drug which is causing a resistant hypertension can be stopped in such a scenario. So how do we actually evaluate these patients? First and foremost, we have to confirm the treatment resistance by looking at the blood pressure and also assuring that this patient is taking his therapy properly and there is no non-compliance. Then you exclude pseudo-resistance by the methods which I have already described. And so, finally, you make a diagnosis of resistant hypertension on assurance of antihypertensive medication adherence with the 3 drugs which I have described and exclusion of a white coat effect. You must always assess for secondary hypertension, aldosteronism, renal parenchymal disease, renal artery stenosis, Cushing syndrome, obstructive sleep apnea, coarctation of aorta, and must always try to assess for target organ damage. You may not always be able to do a fundoscopic examination, but you can do an ECG and echo if you have with you. You can assess for microalbuminuria, and you can assess for the peripheral arterial disease by using ABPI, which is easy in your clinic. But yes, it takes some 5-10 minutes extra. So giving that extra time to your patient, especially the first evaluation of the patient, is very, very important so that you can make an idea about this patient, and then subsequent follow-up visits might be easy for you. And again, how do you evaluate the risk factors for resistant hypertension? The easy mnemonic to remember is A, B, C, D. First is non-adherence, which actually occurs in 50% of individuals. So you must actually ensure that your patient is adherent. You cannot do his urine or blood levels. So the best way is to have a good communication with the patient. And if you are able to explain to your patient in a fashion that, hey, I can understand that you are taking so many drugs and it is difficult, and at times you may miss 1 or 2 drugs, I can understand. Tell me, are you taking your drugs properly? So if you talk in this fashion, the patient may actually come up and say, yes, doctor, I missed 1 or 2 drugs, sometimes it's a problem. And then you can assess, and then you can guide your patient. All this requires time, energy, and patience. Second would be biological and behavioral factors, which include old age, excessive sodium intake, obesity, and smoking. Some of your patients may hide a history of smoking from you. An elderly patient will have multiple other issues like depression and certain family issues. They may have these kind of behaviors, and they may be one of the reasons for resistant hypertension. Chronic kidney disease and resistant secondary hypertension like hyperaldosteronism, sleep apnea, etc. must be ruled out, and finally the drugs which I have mentioned. So this is how you manage. You exclude the causes of secondary hypertension, ensure a good diet, sleep, and a low salt diet, encourage weight loss and exercise, which is also important for maintaining your lipid profile, and then optimize your 3-drug regimen with your RAS inhibitor, calcium channel blocker, and a diuretic. Then, if your patient is still not at target, maybe you need to switch over your thiazide diuretic to a chlorothalidone, which is a longer-acting diuretic, or indapamide, which is a very vascular-friendly diuretic without much of the side effects of other diuretics. Very good drug. Finally, if your patient is not controlled even on that, try with a mineralocorticoid receptor antagonist. The Paradigm trial, in fact, the Pathways trial has significantly shown a beneficial effect of MRAs, especially spironolactone and eplerenone in patients with resistant hypertension. If your BP is still not at target, you do not have clear guidelines, but these are expert opinions. You check the heart rate. If your patient is having tachycardia, add a beta blocker. If still it is not at target, you may use hydralazine. Patients with heart failure and reduced ejection fraction can be given a combination of isosorbide mononitrate and hydralazine. If your BP is still at not target, you can substitute minoxidil. Some people would like to use doxycycline. Some people would like to use clonidine and moxonidine, especially the CKD patients. So that is an individualistic approach, but there are no clear-cut guidelines on this. Finally, you must address what is the specific clinical issue associated with your treatment resistance. Some of your patients might be volume overloaded, so they may need an escalation of diuretic therapy. Some patients will have an inadequate control of the heart rate, so they may be candidates for beta blockers or calcium channel blockers, especially verapamil and diltiazem, which are the non-dihydropyridine calcium channel blockers. Some group of patients would have a low renin and aldosterone levels, and they would not respond to ACE inhibitors or ARBs, and amyloid and low salt diet might be a good therapeutic armamentarium in such situations. And then at times, splitting the dosage of medications might be important to improve the blood pressure control. And I think ambulatory blood pressure and home blood pressure monitoring can give you a good idea. Some patients will have a morning surge of blood pressure, some patients will have evening surge of blood pressure. Then maybe you can split the medications according to the patient's need. And then these are some of the specific clinical issues which I have already discussed, so I'll skip this slide. And so finally, the European Society of Cardiology and the ESH guidelines for the management of arterial hypertension say that use a very simple treatment regimen. Try to use a single pill combination with the drugs which have a long half-life and can be taken once daily by the patient. This will tremendously improve the compliance, and many companies have come up with drugs which are small in size so that it is very easy for the patient to take. The BP control may be improved by increasing the dose of the existing diuretic or switching to a more potent diuretic like chlorothalidone or indapamide if the patient is not responding to your thiazide diuretic, which we commonly use hydrochlorothiazide. And sometimes if your patient has a low EGFR, you may need to use a loop diuretic. There are certain device-based therapies in the form of baroreceptor activation and renal denervation therapy also, which I have skipped in the interest of time because these are not class 1 indications and they do have a role in a certain category of patients. Still, they are undergoing trials, and maybe in the future you will have a group of patients whom you can identify would respond to these kind of therapies, patients who are intolerant to the medications, patients who have side effects with the medications, and patients who have true resistant hypertension despite appropriate dosage of medication may actually be candidates for device therapies. So thank you very much, and thank you again to all the moderators and panelists to give me this opportunity, and thank you to Ipca also for the same.
Thank you, Dr. Samir. That was an excellent presentation. You clearly told us the definition and you must exclude pseudo-resistance and secondary causes and go on to treatment. I'm glad you emphasized on the point of clinicians' inertia and adherence to therapy. With this, should we open the forum for discussion, Rajiv?
Yes, sir. Yes, sir. There are a couple of questions which you have been provided to you. If there are questions from the audience, let us start with them.
Yeah. Audience question, where will they be? Will be in the chat box?
Chat box, yes, sir.
Yeah. There is a question from Khan from Meerut, Dr. Khan. What is the current status of use of fibrates and niacin in clinical practice? Dr. Mittal from Saran.
At the moment, the niacin is out, and fibrates are not shown any mortality benefits, so they are practically also out. So at the moment, if you want to focus on triglyceride is a risk marker, and EPA 4 grams a day is the drug you have to address to residual risk. But fibrates and niacin both are out, convincingly out.
Yeah. I think probably we'll have to wait for a study like, I think Prominent, which is doing a study with the fibrate.
Yeah.
So people expect that it might have a role in those patients who are already on statin, but their triglyceride continues to be high and HDL is low. It may have some beneficial effect. There's a question, is statin helpful in diabetic retinopathy? Dr. Jiva?
To my knowledge, the diabetic retinopathy means that there is an end organ involvement, so that patient should receive high intensity statin to reduce the LDL cholesterol by more than 50%. But whether it has any influence over diabetic retinopathy per se, I am not aware, and I don't think I think it's very unlikely.
Yeah, I
I'm
agree.
aware of a JAMA study. There is a JAMA study which shows that diabetic retinopathy is improved by statin. Not only it affects the cardiovascular system. I am aware of only one study, JAMA study. I'll try to send you the reference.
Okay, but I think anyway it is not widely accepted.
Yes, yes, I agree.
Yeah.
I agree.
Yeah,
I agree.
the important thing is to good control of diabetes for of these complications. I think the pioglitazone. Glitazones were used for prevention of some of these diabetic complications. Any idea? And you remember anything?
Glitazones, it increases HDL cholesterol and decreases triglyceride, but that effect size is probably minimal. So I think that should not be, that should not be a reason to consider glitazone in treating diabetic patients. The indication for glitazone should be to lower the hyperglycemia according to the algorithm rather than to improve the lipid profile.
Yeah. Right. Some Australian study came out saying that fibrates prevent some of the microvascular complications of diabetes. So anyway, that's their standard guidelines. Is there additional benefit of adding vitamin D along with statins in diabetes?
Unless there is a vitamin D deficiency, which actually predisposes to statin myopathy and statin related side effects. So I think if you have any fatigue or muscle symptoms, it is better to check for vitamin D level, and if you find vitamin D deficiency, it is good to supplement vitamin D. But straight away starting patients with vitamin D along with statin is not indicated even in diabetes.
Yeah, I think because some preparation.
I think, Dr. Anger, this is a very important point, what Jeevar has said. Dr. Jeevar has said that there are companies who are making statin with vitamin D and it provokes indiscriminate use of vitamin D. So that is to be deferred unless you demonstrate.
You can develop hypervitaminosis D also. It is vitamin D is not a very 100% safe drug.
Yeah, what Dr. Jeevar said is to be practiced, that you have to demonstrate vitamin D deficiency.
And correctly deficient. Is there any effect of ezetimibe on triglycerides?
No, ezetimibe actually decreases the cholesterol reabsorption from the gastrointestinal tract, and it actually is a primary drug to influence the LDL cholesterol. Now, to my knowledge, it doesn't alter the triglyceride levels.
Yeah, it's primarily a LDL drug, and just adding on, there is Niemann-Pick-like receptors in gut which are upregulated in diabetes. So ezetimibe is a very good drug. Yeah.
For diabetes. Diabetic, it is a very good drug, and I think we should consider adding it.
Good drug. And some of the critics of IMPROVE-IT say that the IMPROVE-IT trial got positive because of diabetic population. If you classify into diabetic and non-diabetic, 5.5% risk reduction, absolute risk reduction in diabetics, and around 1.1 in non-diabetics. So
right.
IMPROVE-IT. So IMPROVE-IT.
That's a point. Very valid point.
Yes.
Yeah, some are very critical of ezetimibe being used as uniformly in every patient population. I try to use it in a diabetic patient without fail.
Yeah. There's one question. Invariably, I use proper doses of statins in every diabetic patient of mine, irrespective of the lipid levels. What are the views of you experts?
No, we have already, there are very clear guidelines which has mentioned that if it is depending upon the age and you need to use either high intensity or moderate intensity, but I think almost all patients, I agree with that, almost all diabetic patients should be on a statin. There must be some exception, except suppose in a below 30-year-old without any effect, short duration diabetes, you may think about not putting them on a statin, but I think I will put them on statin irrespective of any other indication. I will put them on moderate intensity or high intensity statin.
Yeah.
In fact, I am really worried that the statin prescription in diabetes in India is very, very low. That is what I mean, even among physicians who are diabetic. I mean, recently I had a patient who had coronary artery disease, three-vessel disease. I asked him, what is your diabetic status? I said, he's controlled, it's metformin. Then I asked him, what is your cholesterol? He has not checked. He's a physician. He has not checked it within the past 1 year. He's not on a statin. Then I went around, I talked to the IMA and talked about doctors checking their lipid profile. And then I found that a lot of diabetic patients, doctors, they are not taking statins. So this underuse of statins and the fear of side effects is maximum among physicians and healthcare providers. So unless we improve, that if the doctors are not convinced about the value of statin, how can we improve the statin use among the ordinary people? So I am really worried about this problem.
Yeah. Let me bring in Dr. Samir. What is the current state of timing of prescription of antihypertensive drugs? Dr. Samir is there?
Yeah.
Yeah. Do you have the question?
So as I mentioned, that single pill combination with 2 or 3 drugs is the drug of choice. Usually it should be given in the morning, but there would be a category of patients who would have a morning surge of blood pressure, or a category of patients who are having resistant or difficult to control hypertension. These might be the patients who require an ambulatory blood pressure monitoring or a fair home blood pressure monitoring to titrate the timing of their drug. Sometimes you may need to split these drugs, maybe a drug combination in the morning and another in the evening. And there have been trials which have showed a nighttime drug therapy to be beneficial to prevent the early morning surge, which would reduce to a reduction in the strokes and the MIs, which usually occur in the early morning. But again, I believe that the best time to take would be in the morning, unless and until there are compelling indications to take it during some other time of the day. And if your ambulatory home blood pressure shows that the circadian rhythm of your patient is different, that I think once you must always do an ambulatory blood pressure for the patient with a resistant hypertension.
Dr. Iyengar, can I ask him a question?
Yeah, please. Go ahead.
Doctor, how
Samir.
often in your practice you use that evaluation aldosterone-renin ratio in your patient with resistant hypertension? Because most of the data from the West says that it is much more common than what we have thought about. Around 15% of patients. So unless you look at the aldosterone-renin ratio, you will not be able to detect that group of patients with the primary idiopathic hyperaldosteronism. So I think we should have a low threshold to check aldosterone-renin ratio, and if the potassium level is less than 4, all the more reason to check your resistant hypertension patient for aldosterone-renin ratio, which is a definite clue patient will benefit.
Yeah.
What is
Should
your
look at
feeling?
serum potassium. Yeah, Dr. Samir.
Yeah, I think that is perfectly put. And yes, the initial potassium level, and at times your patients who are not getting control on your classical agents like ACE inhibitors, ARBs, calcium channel and diuretics, you must always have a very low threshold for looking at this abnormality. And I do it, and at times I take the opinion of my endocrinology colleague also, because these are factors which would decide the choice of your therapy, and sometimes you may actually need to start them early on MRAs, and MRAs may do a wonder job in them, especially eplerenone without side effects.
Right.
Dr. Iyengar, I just want to come in. I just happened to talk about one of our patients was referred by me by my endocrinologist colleague, and they picked up this hyperaldosteronism and was subsequently operated. Of course, we don't have this facility, and I think 90% of the country doesn't have the facility, which is a textbook confirmatory test what Dr. Jeeva said. But I personally feel in these situations like unprovoked hypokalemia, small dosage, and you feel this guy at just 2.5, what happened to him? Or 33, only 1/3 of the patient have so-called hypokalemia on your routine investigation. All of them don't have. So if you have suspicion of this, this is a difficult, expensive test. I want to seek your opinion whether we can subject these patients directly to MR imaging to see whether there is some kind of adenoma or not.
Yeah, if you suspect, definitely yes. As Dr. Jeeva said, there are some clinical clues. One is when it is difficult to control hypertension. Then you do is serum potassium, and particularly serum potassium is on the lower side. Particularly the patient is on ACE inhibitors, and despite that his potassium on the lower side, again you suspect, and those are the patients when you should subject to MR. Not all patients have hypertension. The hypertension well controlled.
Ratio is a difficult test.
Difficult.
No, but I think it is widely available now. I think in Kerala it is widely available everywhere. But
this is
maybe
in the state of
we have been doing regularly the aldosterone-renin ratios, and the yield is very good, not bad, not very good.
That is when you suspect, isn't it? When you suspect, you do it, isn't it? Not in all patients.
But
only when you're resistant hypertension in patients.
Yeah, definitely.
Hypertension,
yes.
You have ruled out white coat effect. Then I think another factor which we have found in our patient is alcohol. Because people believe that alcohol is a vasodilator and lower in blood pressure. So many people have a misguided idea that alcohol is a hypotensive drug. In the contrary, if your patient is taking 2 to 3 pegs of alcohol per day, that could be one of the cause for that he has highlighted. But I think we should highlight it again.
In the clinical history, yes, exactly. Yeah, one question. Is there any difference between resistant hypertension and refractory hypertension? And current status of renal denervation?
I would say I have clearly mentioned what resistant hypertension is. There's another entity known as difficult to treat hypertension. So I would say these are semantics, but ultimate endpoint is the patient is not getting controlled despite whatever you are trying to do. You have ruled out the reversible causes, you have ruled out the barriers to adherence, you have ruled out the drugs he is taking. And suppose this patient is a true resistant hypertension now, this patient might be a candidate for renal denervation, but yes, the data with renal denervation is conflicting. There was a lot of interest after the Simplicity 1 and 2 trials, but when the Simplicity 3 trial was done with a sham group, it was seen that probably it doesn't work much. But yes, the procedure is usually safe. It is durable at least up to 3 years. But again, we need to identify who are the patients who will actually benefit with renal denervation. And some of these patients are obesity-related hypertension patients and patients who are responding to calcium channel blockers and diuretics may respond to renal denervation. Patients who are responding to the ACE inhibitors or ARNI may not. So still there is lot of interest which is developing. The renal denervation which was initially done, some of the authorities who actually potentiate this therapy said that probably it was done wherein only 50% of the renal arteries were denervated and maybe the ostium and some branch renal arteries were denervated. But if you go distally, if you have better catheters with multiple electrodes and you are able to denervate almost 80% of the arteries and you have experienced operators, this might prove to be a beneficial goal. But I think again it's an invasive strategy, and if you have good drugs and if you are able to take care of many factors, the proportion of patients requiring renal denervation would be minuscule, and I think that would be a very rare category of patients.
I think just want to add, people have defined the refractory hypertension, it's just semantic as you say, those people who are on 5 antihypertensive drugs and their blood pressure is not well controlled, they call it refractory. It's just a semantic, you have to just investigate them further. Come to renal denervation, yes, earlier probably there is some sort of learner's curve. You have better hardware now and better techniques of doing it. You don't not only do it in the main branch, you do it in the branches of the renal arteries. So that might definitely give better results. And proper selection of patients also very important. And I think renal hypertension trial which is going on, they think is very promising and very encouraging results. And the another device closure or invasive method is create an arteriovenous fistula. You put a conduit between external iliac artery and external iliac vein. That they have tried in some of the resistant hypertensions, which are not found any drugs, and they have found some good results. But these are, I think, heroic measures, which I don't think will require. They've got very effective drugs. Role of saroglitazar in decreasing triglycerides.
I think saroglitazar is an effective drug to reduce triglyceride and increase HDL and probably a mild effect in LDL lowering. However, we don't have any outcome data with these drugs. So that is why most of the guidelines about triglyceride, ADA guidelines, anyway, they about triglyceride, they are probably saying that because anyway we are using statin in diabetic with so we have to be cautious when you are adding another drug, and I think unless we have more data, I think the routine use of saroglitazar in patients with diabetes, I think we have to wait.
Yeah,
I think Rajiv Agarwal Rajiv can talk about, because you are a lipidology specialist.
No, I'm not. I'll say what I agree with you that it works very well in NASH, and most of the data with this molecule is, to my mind, is a cosmetic correction, if you permit me to say so, and company may be annoyed with me. So I say it cosmetically correct the lipid profile, since we don't have the outcome data, but it's a very annoying, my personal comments. So we have not gone with this molecule to cardiovascular system. Is still in the domain of endocrinologists working on liver. That is all I can say. So in the absence of outcome data, adding another drug is not a good idea. It's an expensive molecule also.
Do statins act on all LDL size particles or only on large and medium sized particles?
Okay, I see that question, very intelligent question, because but I think the statins act by inhibiting the synthesis of cholesterol in the liver and then upregulating the LDL receptors on the surface of the liver. So the LDL receptor, whichever has the LDL apolipoprotein, will be taken up by the LDL receptor. So to my mind, I mean, theoretically, a statin will lower all types of LDL irrespective of the size. So,
very right. Yes. I think this question I already answered. Can we safely give atorvastatin in fatty liver with type?
Yes, I think there are studies looking at this in non-alcoholic fatty liver disease and diabetes, and people have found that in most patients, atorvastatin, statins are well tolerated in NAFLD and improve, actually, contrary to what was expected, improve the liver enzyme level and even liver histology. There is a study called the Greek study which has showed that there is a very small percentage of patients have any aggravation of liver enzymes after that. So I think you can safely, only thing is you need to monitor the liver enzyme, and that is okay. But otherwise, I think simply because there is a non-alcoholic fatty liver disease, you should not stop using statin in diabetic patients. Yes.
It might even improve it. It might even improve it. Yeah.
Up to 3 times. Up to 3 times it is permissible. If you are beyond 5 times, then you have to stop it.
Enzymes, yeah.
No, that is when you start it in a de novo patient, and when you find that the liver enzymes are increasing, then that is statin related. Yes. Here the question is, already the liver enzymes, suppose there are 200 liver SGOT, SGPT, more than 3 times normal. De novo starting it, we can start in small dose and see how the liver enzyme respond. And according to the Greek study, these patients, the liver enzymes come down.
I agree. I agree.
Interesting question. Role of ARNI in resistant hypertension. Samir?
Yeah, so yes, ARNI can be given, but again, it is not an indication. In fact, sacubitril valsartan has a role only in heart failure. Yes, there are two new drugs. One is firabastat, which is undergoing certain trials, and second is ARNI, which can be used for the difficult to control and resistant hypertension, although the company doesn't promote it. But yes, because of its effect on the BNP, I have tried in a few of my patients. I don't think it will receive much of an indication for resistant hypertension because of the commercial aspects also. The Novartis is promoting it and it has been seen to work. It was tried only in heart failure trials. But yes, there is a role of ARNI, and at times if your patient is not responding to an ACE inhibitor, ARB, calcium channel blocker and diuretic, maybe adding an ARNI, especially because of its neprilysin inhibition, may work. And there are data, and probably I was reading that there would be some trials or short studies which may actually look at the role of ARNI in the future. But when I talk to Novartis and company people, they are very clear. They don't want to promote this drug as an antihypertensive drug. They are focusing only on heart failure.
The heart failure drug. And it has got valsartan, so it might have some antihypertensive effect along with
Dr. Iyengar,
yeah.
ARNI came as an antihypertensive drug.
Yeah.
ARNI was not a drug which came for hypertension with the reduced EF.
Yes.
So ARNI can be used in hypertension. Nobody promotes it. That
Nobody
I agree. But
yeah.
I use in 2 to 3 patients every year. And I'll say they are on 5 drugs. You will be surprised. I just put them on 200 milligram twice a day. I have very good experience. They work very well. My success rate is about 60-70%. So from 5 drugs, they come down to 1 drug and a diuretic. It works very well. This year I have used in 1 patient 200 milligram twice a day with chlorthalidone 12.5. Patient is doing good.
That's good. That's a good news. Basically, it's not a but I just say.
I'll say try it. It won't disappoint you.
Yeah. It has got valsartan plus neprilysin inhibition.
Mention it, but I think it's a very good practical wisdom to use it as a good antihypertensive. But I don't think guidelines will ever promote that.
No, it can't be step 1 drug. It can't be step 1 drug. It is in a refractory resistant hypertension, difficult to treat hypertension where you are frustrated, patient is frustrated. You want to do something before doing anything big.
Yeah, now the question. Do you have some more questions can be taken, Dr. Raji?
Yeah, why not? I tell the company people permit another 1 or 2 questions.
Okay. Who are the patients who need FOB or LDL number or size estimation?
I repeat the question.
FOB. Patients who need FOB or LDL number or particle estimation.
You see, conventionally, the whole thing is based on LDL, and various guidelines do not want to change it to ApoB. Theoretically, ApoB is more sensitive marker of atherosclerosis. There is no doubt about it. So at the moment, guidelines don't want to confuse the community and the doctors by bringing in ApoB levels. ApoB is not done everywhere. So let us see, if you do non-HDL or LDL, you are still meeting the demands, and still the majority of the guidelines are LDL driven. What you say that LDL particle, there is a school of thought which says that if your LDL is normal, you are having normal means within the normal range, and even then patient is throwing coronary event, it is good idea to do LDL particle. But let me say, our guidelines do not mention ever LDL particle numbers, any one of the parameters to be started with to monitor in follow-up. So LDL particle is still a research tool, not a clinical tool. That is my take.
Yeah, I agree with you.
And to estimate LDL particle number require a very complicated, sophisticated equipment, isn't it?
Yes,
You read
yes.
NMR.
It's only the experimental and this.
So
Also,
let us
as
focus
you
on
rightly say, it is non-HDL cholesterol is poor man's FOB.
yeah.
If you do non-HDL is good enough, you get good idea. So in patients where LDL is well controlled, when probably patient continues to be at ACVD risk, then you might think of doing FOB. And I think
You see,
national
each particle
technology in US
has one FOB. Each particle has one FOB.
Yeah.
So
Yeah.
it is more or less what you said, that it is a poor man's FOB, and guidelines are still LDL driven.
Yeah. I think that's it. In metabolic syndrome, last question.
Yeah.
Do PCSK9 inhibitors have anti-inflammatory effect just like statins? I think answer is no. Right? Agree with me, Doctor?
Yes, I think so. The PCSK9 do not reduce CRP, but PCSK9, unlike a statin, reduced LPA. So that is one thing where they compensate for inflammation, but they, unlike statins, they do reduce LPA. That is another upcoming thing in residual risk.
In metabolic syndrome, why no LDL but only triglyceride or HDL for risk? Metabolic syndrome is something like a pre-diabetic picture.
Yeah.
So same physiology will hold true. I think that's all the questions. You have anything more to say, Dr. Raji?
No, I don't have anything.
2 points. I would like to add 2 points just out of interest. Since we are in the COVID era, the COVID has something to do with both diabetes and hypertension. There's a bidirectional relationship between COVID and diabetes. So diabetic people are more prone to COVID infection severity, and people who develop COVID, they have found out that new onset diabetes is in patients is beyond the stress factor. So they already started one trial where they're doing a registry of all these patients. Second one is in hypertension. Don't stop your antihypertensive drugs like ACE inhibitors, ARBs in COVID patients. So there's 2 things I just thought I would mention.
Sure,
so
sure.
I think it has been an excellent presentation by all the 3 speakers. I really learned quite a bit. I'm sure so did the people who logged in to this webinar. And I thank the organizers and thank Raju in particular. Thank you, Dr. Raji. You want to say?
And let Mr. Johnny Edwin come in and he will close this symposium.
Yeah.
Johnny, are you here? Yeah.
Yes, sir. So good evening, doctors. It's indeed a great learning for each one of us, and we had more than 1,400 logins, close to 1,400 logins for today.
It is because of Dr. Iyengar.
Also.
At the outset, our heartfelt thanks to Dr. Iyengar for his excellence moderate as usual with
Thank
this presentations as well. And of course, it's a great, our heartfelt thanks to Dr. Rajiv Arwala, Dr. Jeevan Sakaria, and of course Dr. Samir as well for their lucid presentations, and which was a great learning for maybe for every one of us here. And we also learned a lot as well, and a lot of information. I thank all the doctors who were present and who were logged in and were patiently listening. And of course, it was a great that Dr. Iyengar has addressed all the queries which has come, most of the queries which has come in. And we heartfelt thanks. And we also express our gratitude to the entire medical fraternity for the initiatives and the steps that has been taken towards this COVID era in terms of fighting this pandemic. Our heartfelt gratitude to every medical fraternity. Thank you, doctors, for your valuable presence.
Thank you.
Okay.
Good night. Good night.
Thank you, Professor Iyengar. Thank you, Samir Kappa. Thank you, Rajiv, again. I mean, we should meet again.
I'll try to send you the paper if I find.
Okay. Right.
Thank you.
Good night.
Thank you, sir.
Good night.
Thank you, all of you. Thank you. Thanks a lot.
Bye.
Thank you very much, Dr. B.
Sir, you can press the red button to end the call.
Has stopped.
Sandeep sir, so I am dropping everyone now.